Well, hello there, listeners. It's Susie New from the Australian Society of Anaesthetists, and thank you for listening to our podcast. It's called Australian Anaesthesia, and it's where we talk about all things relevant to anaesthesia here in Australia. Before I dive into who and what we're talking about in this episode, I want to try something a little different. Firstly, for context, this is the first intro I've recorded since we had the fantastic National Scientific Congress in Canberra. Well done to the organising team there. It was a great meeting, and as always, it was great catching up with so many people. I want to say a really big thank you to all the people who came up and said hello to me and mentioned the podcast. In fact, some people specifically sought me out because of the podcast. Big shout out to you. I think there was Zane, Ryan, and unfortunately I have lost the piece of paper that I used to jot your names down. So big apologies if you did come and say hello and I said I'd give you a shout out. Do email me so I can go ahead and do that. Anyway, we had some really good conversations about the podcast, so I thought I might tackle some of those questions with each episode as a little intro, because on reflection, I thought some of the tips and things I've learned through podcasting have been useful for me, and hopefully these might be useful for you too with your patients, your leadership development, or even if you're giving a presentation. These are all things which I'm interested for all of us to do well, myself included. So to kick things off, the question or the comments I get a lot are to do with my voice. First of all, thank you for those lovely comments. They tend to be along the lines of me having quite a calming voice, and the question that usually goes with that is whether that is intentional or whether I have trained in it. So first I want to answer, yes, this is my natural voice, but also during my podcasting course and in my podcasting network, we do discuss voice work. And so I suppose, read about it, listened to it, watched it on YouTube, and practiced it with some of my podcasting peers. If you're not a podcaster, what can you take away from this? For this, I want to point you in the direction of a chap by the name of Chris Voss, who is a former FBI hostage negotiator, who does a lot of work on negotiation and coaching for people in business as well as in the FBI for handling these tricky conversations. And he coins the voice the late night FM DJ voice. This is what he says is the default for hostage negotiators. The characteristics of it are speaking slowly, deliberately, and with a downward inflection at the end of a sentence. It comes across as being reassuring, possibly curious, and what it does is it slows down the thinking of your counterpart, keeps them calm, and also helps to create a sense of authority. So an example, one of the questions Chris Voss encourages us to ask is, how am I meant to do that? If I ask it as how am I meant to do that? That tone implies that I think the question or potentially the person who asked that question is stupid. I'm sounding a bit defensive. If I ask it as how am I meant to do that? I convey curiosity, collaboration, and hopefully I'm inviting the person that I'm asking it to be part of finding the solution. He, of course, is an expert in this. He goes into it in much more detail. I encourage you to either read his book, listen to his audiobook. He's got an extensive library on YouTube and you might be able to find it on a podcast somewhere. But he talks about this a lot and he does it really, really well. I know we are not hostage negotiators, but this might be useful for negotiating with patients or colleagues in our clinical and leadership work. So potentially during this podcast, you might be able to hear when I use it. I'm often also approaching my guests with curiosity, and some people when they get on the podcast are a bit nervous, not in this case, but I'm also trying to use it to convince a sense of calm because I want them to be in a calm, explanatory state of mind when I am asking them some questions, potentially some tricky questions. Anyway, think about it, try it out if you want, reflect on it, let me know what you think. And also let me know what you think about having these little podcast/communication tips included. All right, moving on. My next guest is Dr. Magda Simonis, and she is a tour de force. I've had the great fortune of meeting Dr. Simonis through our roles on the AMA Federal Council. I always love catching up with her, and I went and said hello during the AMA National Convention earlier this year, and we had this conversation, and her ideas just blew me out of the water because I, like hopefully many of you, have my own GP, or At least I think I do. But after talking with Dr. Simonis, who is a GP herself, I see that there is a whole lot more I could be doing with that GP, with that professional relationship to keep me healthy. And I like to think of myself as someone who knows about healthy lifestyles. You know, I love exercise, I love eating really well, and I thought I knew a thing or two about preventative medicine. But one thing this conversation did highlight to me was how much there is out there, and really, when it comes to my own health, it's best to leave it to the experts. All right, enough about me and my health. Let's get into it. Thank you. Thanks for giving up some time.
Oh,
you're in Melbourne, so this is grand final public holiday for you too, right?
Indeed, it's one of our prized days off. So I have a long weekend, an imposed holiday.
I'm so honoured that you're spending part of your public holiday with me. Thank you very much.
It's fantastic. I'm really happy to.
I just love that conversation that we had at AMA Federal Council, and I wanted to share it with all the people that listen to the podcast. So I was hoping we should just go through some of the things that you talk about with your patients as a GP through the lens of having a patient who's medical, so perhaps through different stages of their career. And I know you've got a big focus on, not just a big focus, but I know you are an expert in women's health. So did you want to focus on women in particular, or did you want to tackle
Not really,
both
because
genders?
I see an equal number of males and females. My practice is really mixed. And I see a lot of male colleagues. So I think that is also something that I'd really like to talk about because, well, one of the things there that, you know, you uncover, much like our conversation at the AMA NatCon, is that they can get to like 60, 65 and have never had a GP. Never. And in fact, they're rather proud of it. So I think one of the difficulties, and that's not just for men, I mean, for women, it's quite different because they'll need to have a cervical screening test, they'll need to have their breast checked, or they'll need to come and see someone for their hormone replacement and all the other gynecological things that force women to see a doctor. Whereas men don't have those prompts throughout that phase of family building, which is where so much of their need gets, you know, really unserviced and unattended to. And I think one of the things I have to say up front, as a doctor who sees quite a good proportion of doctors, is that they're not good patients. So, and it's across the board. I don't think it's discipline specific. I think it's just that we know too much. And I think to some extent, everyone assumes they know more than the GP they're sitting in the room with, especially when they're not a GP. And they basically don't come for recalls. You have to chase them up to give them their results. You have to chase them up for their recalls. They'll book appointments they don't come to. And then there's the sort of the casual, Friday night, you get an SMS, Magda, I'm out of a script, or can you write me a referral too, because I'm going to go see, I've already made an appointment for, and you don't really know what it's about.
Yeah.
So there are all those sorts of intrusions, and establishing that professional boundary or professional relationship is something that we need to try and learn, because I think that I've been a patient and I know that when I've had to make decisions about something, I've really enjoyed trusting the expertise of the person that I've gone to see, and I've let them really guide my decision rather than the other way around, even though I've had lots of questions. I mean, questions are fabulous. Having the dialogue is wonderful. But saying, no, I don't want to have a PSA at the age of 70, I've never had one and I have no symptoms, makes me feel a little uncomfortable as a GP. I think saying I don't have any health issues, I've never really needed a doctor because I've been really well, and then they have a blood pressure of 158 on 95 and they had no idea, and you don't know how long they've been walking around with that for. There are lots of things like that that we discover.
I'm glad you brought this up because I did want to bring it up at some stage in the podcast, and that is what it's like for doctors to see a GP. And you've definitely mentioned some of the barriers there. One of the barriers I find that I have is I think my problem is too small to handle, too small for a GP. Oh, this is just something I can just take some Panadol for and it will go away. And you feel like, oh, you're just wasting someone's time. And you've got a really great strategy, I think, for that, particularly for as your patients get on a bit. What do you do?
Well, I treat my doctor patients as much as the way I do everybody else. I just say, you have to book, and really you should book a regular health appointment once a year with your GP. And you should be well when you make that appointment, and expect that on the day that you come, you've probably got not much to talk about. Let the GP sometimes guide that by asking you some questions that you might not have thought about, or bring your questions with you. For instance, there will be the routine screens, the preventative health checks. In general practice, what we talk about the preventative guidelines according to the phase of life that you're in, right? The stages of life. And certainly we should look at doctors in the same way, the different phases of life that you're in, but also the different stages of your professional career that you're in, and the demands that that imposes on you really impact, I think, to some extent, all the other health factors too. So the busier you get, the more research you do. You sit more, don't you, when you're researching? You're sitting in front of a computer, then you see your patients, then you're rushing home, then you're doing the quick meal, then you're having a bottle of wine or something to wind down, or with your partner. They're the sorts of things that just get absorbed into life and don't get broken down into impacts on health, potential impacts on health. So lifestyle and the context and the stage of life that you're in is really important. They're all very important. So as a GP, I encourage that kind of book an appointment regardless. So when you receive that email from me, or that message from our practice that says, your time for a health check with the doctor, just book it in.
That's mind-blowing to me. So you want us to make that appointment when we're well. I love that concept. I think almost everyone listening to this podcast go, that's not me.
Yeah, because prevention happens when you're well, doesn't it? It does not happen when you have a symptom or a condition. And this is also the opportunity we have to talk about prevention. And that includes a variety of things, from vaccinations to skin screening for women, knowing your breast and making sure that throughout that life cycle we have an understanding of what those changes are like, and making sure you're having your breast screen, knowing your family history, knowing your family history, and what genetic predisposition you might be exposed to from early on down the track, things that we need to be aware of. In terms of mental health, family history, your own personal mental health. Did you have mental health issues when you were a young person, through high school, through secondary school? What are the triggers? What are the sort of circumstances that might bring these things out, and how are things at work? A lot of it has to do with our mental health too, because so few of us are willing to talk about that until something really, really goes wrong and we're not coping. And I think that we carry a lot of stress. I think we carry a lot of pressure. The expectation we impose on ourselves to always be at the top of our profession, doing really well. Every interaction we have with a patient, we've got to be switched on, regardless of whether we've got pain, whether we're hungry, full bladder, a headache, or something terrible going on in our personal life. And wearing that mask and really having to bury that takes its toll. We're human. So there are opportunities to talk about that. Then for women, obviously the reproductive stages of life. I like to talk to our women doctors about preconception counselling. I think that's really something that we don't take into consideration. Even professional women who you think will time their pregnancies end up pregnant unexpectedly sometimes, and it really throws a spanner in the works for their stage of life and what they're doing. So there's sometimes a bit of a crisis around that. So preferably planning those opportunities. I also talk to my female patients who are doctors who are outside of a relationship, not yet in a partnership. Women face all sorts of, and men too, but in particular women who haven't partnered yet. They haven't met the right guy and they would love to have a child. They would love to have a family. So I talk to them about freezing their eggs, looking at other options. Have you thought about down the track? Have you thought about where you're at when you're 40, when you're 38, you're now 32? Have you given this some thought? I just plant that seed. Yeah. And some have said, now. And I say, well, give it a thought. If things happen, but this is the perfect time to be saving your eggs, if that's something you really want in your life.
Particularly for an anaesthetist, that's the time in your life when you're caught up with exams, trying to finish training, and you're not necessarily thinking about your future self and what that looks like in a family context. And you may not have had someone to say, hey, have you thought about that? So that's a really good point.
And then, of course, for men and for women, the baseline cholesterol, knowing it at some stage in your life, knowing what your diabetes risks are, doing the cholesterol, urea electrolytes, uric acid, liver function, general screen. In women, of course, anemia, that's, low iron. We need to have that baseline at some point.
What age do you start thinking about doing those baseline tests, roughly? I mean, obviously it will depend on history and other things going on.
Where there's a family history, this is where family history comes in and is really important. If there's a family history of heart disease, I'd suggest it even in their 30s. Yeah. Certainly, because prevention, again, happens when you're early, before the disease occurs. We know that atheroma, by the time you're 40, 45, you can still have significant atheroma. So it is worth knowing. I've picked up with one young man, both his parents are my patients, and they've both got hypercholesterolemia. So when he attended my rooms at 25, I did his baseline cholesterol. He came for something completely different. And he has familial hypercholesterolemia and he's on medication. So, under a cardiologist. So these are things that we do need to know. That's why knowing your family history is very important.
Yeah. And I remember being offered screening sometime in my 30s or early 40s or something. And I just thought, what now? I mean, like most other doctors probably, I'm fit and healthy. I exercise, I eat well. Like, why would I want to check my cholesterol? I thought that was pretty mind-blowing to be offered it by my GP at the time. So I'm hoping someone out there listening might also have that little bell ring to make that appointment with their GP to go for that preventative screening.
I think it's also important, you see, this is the other difficulty. A lot of our colleagues, anaesthetists who understand physiology and biochemistry so well, you're the experts in this, will self-manage that. Now, I think, so I have so many on medication that has been prescribed by, who prescribed?
It's very easy for us to slip into work and check our own blood pressure.
And these are the sorts of conversations I have often with my patients who are doctors. And I try not to be judgmental because it's important not to be. I understand it's the pressure we're under, and time is pressure. Time is also money. And why should I see someone who's just a GP for something as simple as this?
That's coming back to that other point I was making. It's like, well, if it's just my blood pressure, I can take a tablet and I don't want it to disturb. I don't want to waste someone else's time. This is simple, I can handle this. That's the kind of mentality.
Yeah. So they're the sorts of things in terms of preventative and early things. And certainly as we're approaching 40. So at 40 in general practice, we have the 40 plus health screen, which is where we do the baseline sugars. Yes, so looking for diabetes, the risk, and also the cholesterol. So that is a government-funded MBS item number. Yes, and you can book a long appointment. You do the full adult health check.
So people in their 40s, we should be getting into
At 40.
At 40.
At 40 on the knocker. So, yes.
Check our sugars.
That's right. And with women in particular, I talk to them about their breast cancer risk depending on their family history again at that point, because waiting till you're 50 is quite a long time. So then from 45 onwards, we have the other 45-year screen. So if all's clear at 40 to 43, you don't really need to do another blood test if everything's fine.
Do you throw in an ECG? Or should that also be getting done in our 40s?
Not necessarily, no. ECG does not. And screening ECGs are still charged. Certainly if there's a history of arrhythmia, if they're having palpitations, I definitely would, because you do have the conversation around heart health. It's never too early to start, but we do have that particular trigger point in our program, in our preventative health program. Then again, at 45 to 49, we have the other health check, which is the 45 to 49 health check, which is when you're called into the doctor's office to have your health screen, which includes a review of your cholesterol, your sugars, and your other heart disease risk factors. Now, we also have the fecal occult blood test, which is available from 45 onwards. And although you will not receive the prompt from the government in the mail, you can just Google order poo test and click on that.
I love that. Order poo test.
I do that with my patients all the time. In fact, when they say, oh, no, I say, have you done it? No. So I say, write this in your thing. And they write it and I say, no, I can press enter and it comes up. They say, order poo test, just that. And I say, yes. So we have a bit of a giggle. And then scroll down. The first or second item is National Cancer Australia order kit. Click on that and order your test then and there. And they'll send you a kit at your home. Easy peasy.
So you can opt in from 45, but then they send it to you
from 50 onwards.
From 50 onwards, yep.
That's right. Of course, the blood tests, right? And that includes your blood pressure, weight and waist measurement, and looking at all the other health factors, your immunisations, mental health, and your cancer risks. And then from 50 onwards, with both men and women, we've got the regular health checks, which include the fecal occult blood tests. I do maintain that men should have a PSA, certainly the prostate-specific antigen. If there's a positive family history of that, of a father, a brother, certainly under the age of 60, I'd recommend doing a test somewhere around 45 or even earlier as a baseline, and especially now that there's a charge to that. I think the MBS rate of that is now probably about $50 or $60, but I think it's a worthwhile test to have. I've detected early prostate cancer in younger men, and it's alarming because you think, yes, how aggressive would this be had it been left another 10 years? And I think that they're asymptomatic, but it's just one of those accidents that occurs now and again. And I think that we need to encourage our male colleagues to have their PSA. There's nothing more devastating than hearing that, someone that you're managing who's not had this done or delayed it or didn't want to do it ends up with a prostate cancer. And you think, really, the PSA I would certainly recommend. And certainly with a family history from 40 or 45, depending on the family history, and certainly from 50 as a baseline, definitely. And then you see where they fit in that sort of range. And so if they're under, 0.9, then you can not do one for another 2 or 3 years. But if they're over, say, 1.2 or something, then you'd probably check it again in a year or two.
Yeah. I wanted to ask, hypothetically speaking, or I have a friend.
Yes, I have a friend. We all have a friend.
We all have a friend, probably some of the listeners, who perhaps got to a certain age, 50, 55, 60, and they haven't done any of their screening. Don't see their GP regularly. They've had the letters coming from the government. They've been asked to do a poo test. They've been asked to do breast testing. They're due for their cervical pap smear. And there's a lot of things on that to-do list. So how can they prioritise this list?
Yeah, that's a really good question, Susie, because it's a lot of time that's involved in having your fasting blood tests. So you've got to time that in the morning. So if you're an anaesthetist and you've got early lists, how early is early for you? For you, 8 in the morning is late in the day.
Oh, yeah.
So that's when most of the pathology groups open.
Yeah.
So timing that fasting blood test, unfortunately for us, tends to be hopefully on a Saturday if you can find a place near home. Admittedly, I do them opportunistically and I just say, look, you're 50, you haven't done anything. Why wait? You can read the room, read the situation and make it as easy as possible. So certainly with the bloods, I just take the opportunity and do them as they are, even though they're not fasting. And if there's something abnormal there, then you talk about that. And they're usually quite interested in knowing what their fasting blood levels are after that.
True.
Even more so. And then we should do maybe, say, 3 or 6 months down the track after that conversation around, a bit of weight loss, a bit of management of diet. Let's recheck this in about 3 to 6 months, yeah?
Mm-hmm.
And so certainly the poo test is a pretty easy one to do. I encourage patients and doctors in particular, I describe what it involves and it's really not intrusive at all.
Mm-hmm.
It's harder for those who don't have a regular bowel pattern because you do need to have 3 separate samples. And if you poo every second day, which a lot of women do, not as regular as men, that can make it a bit of a drawn-out process.
Mm-hmm.
No one likes harbouring a little specimen of poo in their fridge at home.
No, I didn't realise it's got to live in the fridge too.
There's certainly skin checks every single year, and I encourage self-checking,
Mm-hmm.
self-testing. So examine your skin, know your skin, but your GP can do that. You don't need to see a dermatologist. If you've got really complex skin, you've got really fair skin with around 200 dysplastic-looking nevi, then certainly have a regular relationship with a dermatologist.
Mm-hmm.
That's something that I encourage. But for the most part, most GPs will do the skin checks. I still remove lesions where they're undergoing a bit of change, make it easy for the person. Let's just whip it out. Let's just do a quick biopsy. And if that needs further excision, then refer to a plastic surgeon.
I love that you as a GP add that perspective because I think that's often what doctors can also lose perspective with is when do you go to a specialist and when can you manage it with your GP?
Well, the thing is that a lot of my colleagues that end up in my room end up admitting that at some point they had a colonoscopy or they had a stress echocardiogram or they had this, but they never saw a GP for any of that. They tapped on their cardiologist friend who did the test. And that's all good, but no one's actually looking after their holistic care.
Yeah.
And no one's monitoring the progress of their condition. There are other aspects to health other than investigations that are either proving you've got a condition or not got a condition. So it's not just about having a condition, it's about knowing what else is potentially going to go wrong or how you can support your health better.
Yeah.
So a lot have been on medication without ever having seen a GP. That shouldn't be the case. You've got to have renal function, chats about that, outsource it, let someone else take care of you. You can have the dialogue. You don't have to come every single time for every little bit. Having a telehealth consultation works.
True.
Once a year, face-to-face. You do need to have the once a year face-to-face. The telehealth is great for all the other interim conversations.
Before I interrupted you, you're about to go on about adding to that to-do list of screening tests.
Mammograms, yeah. Now, look, breast screen, I think, is excellent. So a lot of colleagues want to have a 3D tomosynthesis and ultrasound, which is great. I'm happy to arrange those. They do have a very high false positive pickup rate, however. So things that are identified on the 3D tomosynthesis may well result in you requiring a fine needle biopsy unnecessarily. I think just something for our doctor colleagues here to be aware of, because we all know our area very well, but not necessarily everything else that's going on in the medical world, and certainly in the preventative screening world, which I'm very deeply involved with. I'm also on the Breast Screen Australia expert advisory group as a GP. And so we're looking at breast density now, and there are a lot of changes ahead in terms of the management of different densities of breast. For everyone in the community, I still maintain breast screen is fabulous. It's reduced cancer-related deaths from breast cancer by close to 50%, like some astronomical number, like 43% since 1991. Really amazing stats, yeah?
Yeah, amazing.
So we've all heard the stories of women who've been regularly screened who still have breast cancer. And we know that women who have very dense breasts, and you cannot feel dense breasts.
Right. Sounds like you'll be able to.
No, you can't. So you can't feel dense breasts. So it's not something you can clinically determine. It's only determined, it's a radiological classification.
Oh, okay.
And there's category A, B, C, or D. A and B are not particularly dense, and they have a very high, so the two-dimensional breast screen every 2 years through breast screen, any breast screen you do around the country, be it in a mobile van or be it in a hospital centre, the standard is excellent. They have a really high sensitivity in the mid-90s to high 80s, right? Really high, really reliable. If you have a category C or D, then you have more dense breasts. And remember, nothing you can palpate. So it's not about how your breasts look when you take off your bra. And the two-dimensional breast screen that is available through Breast Screen, wherever you go, and is uniform across the country, does not have the same level of sensitivity for those kinds of breasts.
Oh, okay.
Right? So it might be 67%.
Wow, there's some subtlety and nuance there, isn't there?
There is. So you've got very dense breasts, where we also know there's a higher association with breast cancer.
Yeah, right. Wow. Okay.
And also hormone replacement therapy increases the density of breasts. So we also need to take into consideration. It makes it also harder to detect things in dense breasts.
I see.
So therefore, with those women, with our patients, with our colleagues, we need to have that conversation. We will be having that conversation. It's all going to come back to the GP, because the recommendation issued by Breast Screen Australia and by all the breast screen services so far, the only state that hasn't started informing its clients of breast density is Queensland, but they're to do that in 2026. But all the other states have. So for anyone who's gone and had a breast screen of late, they'll have received a letter saying your breast screen was normal, however you are classified as BI-RADS D. Please speak to your doctor about this, your general practitioner about this, to discuss any further investigations that might be necessary.
So go to your screening, get that ball rolling, then get the information, go back to your GP, start putting the picture together. So, of course, I've been focused on my lane in anaesthesia, and these developments have been changing. I don't do a regular breast list with the breast surgeons. I know some of my colleagues do, so they're probably completely familiar with these guidelines, but for me, certainly not. This is new. Fantastic. This is why you need a good GP.
Yeah. So the question there is, what do you do when you have BI-RADS-D? Do you have just a conversation, say, oh, let's keep going? There is another test that you can do. It is Peter Mac, I Prevent Breast Cancer. It's the tool. It's an online tool. If you have never had breast cancer before, then you can go in. The other thing is, if you've got family history of breast cancer and step relatives, then I think that sort of qualifies you out of doing this screen. But it's a survey and it gives you a sort of a percentage risk at the end of it. It takes about 20 minutes.
Mm-hmm.
So I usually give my patients that link. I ask them to go home and do that. Sometimes if we have a bit of time, if they've made a longer appointment, I'll go through the whole thing with them. We do the survey together. Helps me also understand more about their potential risk.
Mm-hmm.
And then you have the conversation with the GP. Look, your risk category is relatively high here, so we should probably go and proceed with some other test. And the question from there is, what do you do? Do you do the 3D tomo with ultrasound, which of course has a very false positive pickup rate and not that much more accurate than the 2D, not that much more better. But the far superior tests, of course, are mammogram with contrast, CT, invasive, dye, the whole thing, expensive, screening, expensive, or MRI breasts. I mean, who can afford that? So they're the complex conversations that we'll be having with our patients, but also complex conversations that we'll be having with our colleagues around what do we do to better screen you, to better serve you, given you've got very dense breasts. Not only do you need to have your breast screen, but you need to know your breast density. So they're the two key points to take home.
All right. So we've covered doing your poo test. We've covered doing your breast screening. You mentioned doing
and the prostate.
You mentioned PSA before. Anything else you want to add to doing PSAs and prostates?
Just do them.
Yeah.
Really, just do them. I think it's a disease that's so common. I know the older you are, and if it's positive and you develop the prostate cancer, the less likely you are to die of the consequences of it. But there's this whole argument about, do you still do PSAs over the age of 70? We're living till our 90s. I have patients who are living well into our 80s and 90s and thriving. That's when they get into their other phase of life, writing their books, emeritus professors and doing all sorts of exciting things.
That's true.
So I think it depends on the individual. Certainly I recommend doing them at that age. And if it's elevated outside of the range, certainly we have that conversation. If there's a prostate cancer and it's been identified and it's under surveillance, you can watch, and that's usually under the care of a urologist. So that's not going to be managed by the GP. I would refer, right? But you have that three-way relationship, the patient, your colleague, the urologist and the GP, just monitoring that over time.
Okay, so we've talked about breast screening, poo screening, prostate screening for PSAs. Is there anything else that we should be thinking about?
Yeah, sure. I think certainly for everyone, osteoporosis, so bone density, we need to know about that at the onset of menopause, or if there's a family history of osteoporosis that's premature. You've got celiac disease, for instance, or thyroid disease or some other autoimmune disease, or you've been on steroids, or you've got a connective tissue disorder requiring long-term treatment. That can all compromise your bone density. So for anyone out there who's on medication for any of those conditions, bone screening for osteoporosis with a bone density is recommended earlier rather than later. And certainly if you had an eating disorder like anorexia nervosa, where you've had amenorrhea, that's very important for our younger women and for our younger men too.
Yeah, and there's a high prevalence or incidence of that in particularly, successful women who might end up entering medicine, and that's something that they could have forgotten about from their teenage, early adult years.
That's right.
So that's important to think about.
Important to think about. And then there's cervical screening, of course. For women, the interesting thing now there is that you can do it every 5 years. You can also do the self-test.
Oh, okay.
So the self-test, as opposed to having a speculum inserted into your vagina, you can just basically insert a cotton tip. It's like a long cotton tip into your vagina, twirl it around about 20 times, and it really just screens for the presence of human papillomavirus. It's a PCR test, much like the RATs that we do. But I do say to my female patients that it's not a bad idea, given that we're doing them every 5 years. If you've got any discomfort, burning, itch, any vaginal symptoms, it's worth having a physical examination, certainly for vulval changes, vulvar sclerosis of the vulva, which is a precancerous condition, can be quite silent in women, and I've seen it occur. I do like the self-test. It's convenient, it's easy, And I know that a lot of our colleagues opt for that now, but just remember that any gynecological symptoms, abnormal bleeding or outside of your period or postmenopausal bleeding, to have a physical examination. And hopefully I've mentioned also immunisations, right? So pertussis is one of those things that I talk to people about opportunistically.
Mm-hmm.
So it's now, Boostrix, make sure you're up to date with that. We've got pertussis going around, obviously, but in the line of work you're in, and COVID and influenza, really important. Yeah.
And pertussis is an interesting one because we're often vaccinated as teenagers, but the immunity wanes and you're reminded probably when in your childbearing years that it's time for a booster, but then after that, we don't often get another prompt.
Yeah. Look, we don't really know how long the pertussis antibodies last. We suspect somewhere around the 10-year mark. So somewhere around the 10-year mark, just have a Boostrix. I automatically put that in the recall list.
All right. So it is a bit of a checklist, but you can get through it. It is manageable with the support of your GP.
I think it's so important to not self-manage. It's very hard for us to let go of our control, understandably. We can't let go of control in our work, and we can't let go of control of our own decision-making.
Yeah.
When it comes to our patients, you sort of understand that. You want to really protect your patient and do the best you can. But when it comes to you, all our other biases have a role and interfere. So it's good to have that objectivity of someone who doesn't have those.
Yeah. I think this leads nicely into what I've been thinking in the back of my mind. Because we have such a problem trusting someone with this decision making, what are the things we're looking for? How do we find them?
I think it's word of mouth. Ask colleagues that have got a good GP. Say, hey, do you have someone that you could recommend? And most of us will open up another appointment for a colleague. You just do.
Do you think a great GP is a great regardless, or do you think sometimes it's just that you have someone that you click with more than another person, or someone is more able to trust a certain type of GP more than another type?
Really good question, Susie. I think it's both. So a GP might have a particular approach which is very direct or conversational. It depends on personality. I mean, we're human, aren't we? So it's like finding a good counsellor. Sometimes when patients come back and say, oh, we didn't click, and other patients rave about them. They're very good as clinicians. So I think it's the same with doctors. It's great to have a relationship with someone that you don't mind going to have a chat with.
Yeah.
Because a lot of important stuff comes out through the chat.
Absolutely. Yeah. And speaking of the chat, you must have a huge network. You've been president of the Victorian Women's Medical Society. You're on multiple boards. You've been involved with AMA at so many levels. Do you come across your patients in your network?
All the time.
And how do you manage that?
Oh, I think we all sort of do. I don't find that disturbing for me. I say hello. No one needs to know that I'm their GP. But usually they divulge that I'm their GP, which puts me in a bit of an awkward position sometimes, actually, because I want to be seen as not just their GP, especially when we're friends, or not friends, because I try not to see my friends quite seriously. I don't, although friends will ask my opinion, but I try not to see my friends. I will refer to someone else. But certainly, you develop that camaraderie. You could easily be friends, but then you see each other in a professional setting, or you see each other in a meeting on a committee or something else. And they don't need to disclose that I'm their GP unless there's a conflict of interest for some other reason, whether it be research-related project or something to do with that.
I want to come back because I just really want to get this point across about doing an annual wellness check with your GP, making that appointment when you're well. When should we start making that annual check-in?
I say from 18 onwards. I get that drummed into the teenagers. I like to see the students, and I like to have an approach where they feel they can walk in when they're in a crisis, or they have access through telehealth through a crisis, because that's when things really do and can go wrong. I encourage that through the parents. As a GP, I'm so lucky. I see young women in their 40s that I've known since they were 14 for their acne. Now we have these chats about who would have known life was so complicated. So annually, from uni days onwards, there's so much to do, even as a uni student. You've got your STI screens, you've got your mental health, you've got your diet. And sometimes I think we just need to have someone external drumming into us the importance of opportunistic exercise and lifestyle choices. So one of the things you've probably observed in your colleagues over the years, some just gain a lot of weight because it's just lifestyle related. We have difficulty prioritising our health and ourself. We feel guilty when we're exercising and taking time away from doing work. We feel guilty doing things that have to do with us and our personal needs. And drumming that in, you are entitled to look after this. Take the time, do the exercise, choose the right foods. What's your sleep like? What's your stress like? These issues exist all the way through and at different levels.
All right. So take home message, everyone. Annual wellness check. Find a good GP. Start building that relationship if you don't already have one.
Yeah, great.
Is there anything else that you would like to say? This has been fantastic. I hope it's inspired some people to pick up the phone and call their GP. But is there anything else you want to add?
Oh, I just want to say thank you for inviting me, and I hope that our colleagues out there actually do take something home from this and the importance of follow-up also with the GP. So, yeah, the once a year physical check is one thing, but also just make sure that you do have a follow-up. I know you can access your results and you understand them, but it's important also to have that conversation about next steps and next recalls too. And bring your list with you when you do have an appointment. If you do have any issues, bring your list of issues, whatever they are, and talk about them. Hopefully you can feel that you've got a trusting person in that room that you can just talk with about all sorts of things, not just health too, but life and all the other things that impact you.
Oh, wonderful. Look, absolutely inspiring having a chat with you this morning. Thank you so much for your time.
Lovely to see you in this context too. Thank you.
Well, I hope you enjoyed that conversation with Dr. Simonis, and more importantly, I hope that it has inspired you to do one of three things. And they are to, 1, book an appointment with your GP if you're overdue, if you haven't seen them in the last 12 months, just get in there. It's preventative care and it's good for you. Or number 2, ask around, start looking for a GP, ask your friends, ask family who you trust. And number 3, if this is the time for you, if you're at a certain age in your life and you should know what they are because you would have received the letters from the government, then book in for that screening test, whether that be the bowel screening, the breast screening, or book in with your GP for a PSA. I will put the links for ordering a free bowel test kit in the show notes, or you can have the joy of searching order a poo test yourself, as Dr. Simonis suggests. And finally, reminding you to drop me an email if you'd like a shout out on the podcast. I am, as I said earlier, really, really thankful to everyone who came and said hello to me during the NSC. And also let me know, what did you think about my leadership/comms tips from what I've learned as a podcaster that I presented at the start of the podcast? If you want to do some research for yourself, then look up Chris Voss. That surname is spelled VOSS, or in NATO alphabet, that's Victor Oscar Sierra Sierra. And you are looking for a late night FM DJ voice. Did you enjoy those insights? Did you just want to get straight into the conversation? Do you want to hear more insights? Let me know so I can keep developing this podcast for you. The best way is to email me on podcast@asa.org.au. In the meantime, keep being wonderful, healthy, and as always, hope you're staying safe and well out there.
This has been Australian Anaesthesia, produced by the Australian Society of Anaesthetists, with many thanks to host and editor Dr. Susie New, with music by Soda Lime Music, sound and engineering by Bearview, and graphics by the ASA Communications team. For more content, please visit www.asa.org.au.